right, well, it's 9:15. Welcome back, everybody. We're going to get started with our first session of the day. And is challenges and approaches to improving understanding of health insurance, selection, and out-of-pocket costs. And I'm happy to reintroduce Julia Garvey. As I mentioned, she is a longtime navigator and works at Partnership Community Health Center. And I'm so pleased that she'll be leading the session. All right, so I'll hand it over to you, Julia.
Good morning. And my video is disabled, although that may not be a bad thing. But if you want to see my mug, we're going to have to enable my screen. So I'm super excited to be able to introduce our presenters today and this session, discussing the hard part of enrollment when we get to the end of the healthcare.gov application, I think is the most challenging aspect of our work. And yesterday, our qualified health plan presenters gave us some really great advice on how to think about their plans. It all comes down to finding a plan that fits. So we're talking about the importance of matching a plan to the consumer's health needs and budget, understanding plan design, and there's a lot of plans available in most areas, including some of the zero deductible plans with copays for service, bronze plans with copays that make going to a primary care doctor more affordable, and then stressing the things that are free and the benefits of having insurance, not only protecting out-of-pocket costs and mitigating risk, but stressing the free things like utilizing preventive care. Let me see if we've got video yet. I don't have video. And Kim, are you able to share our PowerPoint? And I will introduce our presenters. So today we have Justin Sydnor, who is a professor in the Department of Risk and Insurance at the Wisconsin School of Business. His research interests are in psychology and economics, applied microeconomics, insurance markets, and risk and decision making. And I first heard Justin speak at the Wisconsin Health Literacy Summit, and I still remember something that just rang out to me. And it's this phrase that the most cost-effective plan may not be the most health-effective plan. And I think that's so important to frame the work that we do. Then we're going to have a live walkthrough today by Sandy Van Zeeland, who comes from Van de Hey Financial Services. She's a licensed agent in life, accident, and health insurance. Sandy enrolls members in Medicare Advantage, supplement plans, and prescription drug plans, individual health plans on healthcare.gov, and small group employer plans. Sandy's participated on our REN since the beginning, since around 2014, and she's been so generous with her time and expertise at enrollment events and helping new CACs and navigators understand plan design. So again, our title is a mouthful: Challenges and Approaches to Improving Understanding of Plan Selection and Out-of-Pocket Costs. And if we're ready, I'm going to send it over to Justin to share the messaging that I was so impressed with at the conference.
Sure. Thank you, Julia. And it looks like everybody, we're still working to get the videos enabled for the panelists here. So hopefully you'll be able to see me here before too terribly long, but I think we can soldier on if not. Kim, if you wouldn't mind jumping ahead to slide 4 there. Right now, we're still seeing the first slide. There we go. Great. So I wanted to talk to you today about helping consumers to understand plan choices. And I want to think a little bit about both the cost effectiveness of different plan choices, and then also a bit about the health effectiveness. So Kim, if you can go to the next slide. So, the background for this is I'm an economist in the business school here at University of Wisconsin-Madison. And my background, a lot of the research I do is studying how people make decisions when they have to choose between health plans. And we all know that, there's a bunch of dimensions of choice of health plans. And probably the most important one in a lot of ways is what access to doctors and healthcare providers do you get. So the different networks in the plans, I think, are quite important in a lot of cases. But that's also a fairly hard thing to study because it's going to be very unique to each person. The thing as economists that we've been able to study a little bit more concretely is the question about the cost side of plans, and in particular, the trade-offs between premiums and cost sharing, your deductibles and out-of-pocket costs. And what's come out of a bunch of this research is that people increasingly have a ton of choices to make, and you all see that in the ACA markets where there are often many, many plans. And the research suggests that in a lot of cases, people may have some challenges, and I see we're moving the slides here a little bit, but people basically have some challenges selecting among plan options, and in ways that may end up leaving them sort of with less money than we thought they would. We got video, so we're improving here as we go. And so what I want to talk a little bit about is a little bit of the research around that, and then a little bit about how we might be able to help people with choices. So I just want to talk about how we think about framing decision aids to help people think about the trade-offs between premiums and cost sharing. And then I want to share a little bit of work, and this gets to what Julia was mentioning about the question about a health effective plan, about how different people might react to cost sharing and how we want to take that into account when we're trying to help people navigate which plan might be best for them or not. So Kim, if you can go to the next slide there. And actually, if you're looking there, Kim, down on the very bottom rim, you'll see something that looks like to the right of where it says comments on the very bottom bar of the thing. You'll see that thing that has a little foot. You might, oh, that disappeared. Yep, over to the right a little bit. That'll get the slideshow going for you. A little further to the right, that thing that looks like a kind of pull down screen. Nope, a little further, two more over. Oop. Oh, no, that's just advancing for us. So, all right, we won't worry too much about that. If you can just go back a slide or two for me. So yeah, great. So let's start here as a kind of illustration. And this is actually a set of options that I've studied in some of my own prior work. So this came from a real company that offered these choices to their employees. So what I want you to think about is, suppose you were working for an employer and they gave you these health insurance options. They all have the same insurance company. So in this case, you don't have to worry about how these different choices would end up affecting your network and access to doctors. So you've got these 4 plans, and you can see that they have different premiums listed in that first column there. Oop. All right, looks like we've got it in slideshow mode. So yeah, if we just click forward a little farther. Oh, back one. There we go. All right, so here are the choices I want everybody to think about. And in a second, we're going to launch a poll. So this is our actual interactive moment here. We're going to want to actually have you make a choice. So take a look at these plans. They vary by premium. So the purple plan has the lowest premium, the black has the highest, and they vary by deductible and their maximum out-of-pocket limit. Oh, sorry, if you can stay back on that one for me, Kim, back one slide. There you go. All right, so let's go ahead. So can we launch the poll here? Do we have this poll option loaded up? There we go. So which one would you choose for yourself if you had to make this choice?
And Justin, we'll give that just probably about another 20 seconds here. Just give people a second to understand and kind of choose what they would pick for themselves here. So Perfect. We'll give it just another probably 10 seconds or so, and then we'll close that out and share the results.
Sounds great. Thanks, Michael. All right. Okay, so we can see we've got a pretty nice distribution here with about 40% of the group choosing the purple plan with the lowest premium but the highest deductible. And about 29% down at the other end, sort of choosing the higher premium but a lower deductible plans, lower out of pocket. All right, so let's close this for a second. And if we were in a big room together, we've got a big group today, so it's a little hard to have everybody unmute and share. But I could collect some reasons people would have, and I've done this often enough that I can share, and you could all guess what the reasons might be. So a number of people choosing the purple plans would have said that they're feeling that they can budget fairly well. Maybe they're not anticipating a lot of healthcare costs, so they'd like to take that lower premium plan. And often a number of people who would choose, say, the red or the black plan will talk about the fact that they're anticipating a lot of healthcare needs, and the shock of a large deductible payment may be sort of hard. So Kim, if you can go to the next slide for me. All right, as we move to this next slide here, what I can tell you is that your choice patterns are actually, one back there, next one, there we go, are remarkably, one too far, there we go, are remarkably similar to what we see when we actually studied the company that offered these to people. So at that company, about 40% of people chose the purple plan, pretty similar here. You were a little less likely to choose the red plan and a little more likely to choose the black plan than the employees at that company, but overall a similar picture. And the other thing I can tell you is that it lines up at that company, especially those with lower incomes, chronic diseases, and older employees were more likely to choose the red and black and blue options. And if you're looking carefully at these graphs I have here, you can see that actually I'm calling the red, black, and blue options here dominated options. And I'm going to show you in a second what I mean by that. But if we go to the next slide, there's some research, nope. There we go. There's some research on how people actually make choices when they do this. And most people, if you can click on the next animation here, Kim, most people actually, so we can think about what a hyper-rational econ person would do here. So a hyper-rational economist, when they look at this, would actually make a pretty careful comparison of the money they're going to spend in different scenarios. And if you click the next little graph there, Kim, that economist might actually create a fairly complicated graph that looks like this. And I'm not going to advocate that everybody try to learn how to make graphs like this for themselves. But the basic idea is what we'd want to think about is that as an individual, there's a range of possibilities we might have for our total health bills. So we might have some expectations of how much we're going to go to a doctor, but if we anticipate not needing much, there's still a chance we might be in an accident or get very sick. And, even if we're anticipating some, it could be a bad year or a relatively good year. So on the x-axis here, you can see the total health bills. On the y-axis for each of these plans, you could start mapping, well, what does that mean in terms of spending and total costs for an individual? And as an economist would break this down, what they would start to identify is that in this particular case, it turns out not to matter what level of health bills you would have. Doesn't matter how often you would go to a doctor. You would actually spend less total for the year if you chose the purple plan. So Kim, if you go to the next slide, I've got highlighted here the purple plan. The basic idea is that the purple plan has a much lower premium. And lower enough that the premium savings would cover any additional out-of-pocket costs, regardless of how much your care needs might be. And so, we've got a funny set of little things going on here. But so in this particular case, the purple plan costs about, so if we compare it, for instance, to the red plan, costs about $600 more for sure for the year. Now, it might save you $500 in out-of-pocket costs if you need a lot of care, but that $500 is outweighed by the $600 if what you cared about was total spending. Okay, so from a pure economist standpoint, that's how we might often sort of think about this. And so an economist would likely push towards the purple plan. Now, I'm not going to necessarily try to argue that that's the right plan for everybody, but I think that comparison is an important thing to have in mind, that sort of trade-off, a trade-off between premium and out-of-pocket costs here. So if we go to the next slide, there's been some research, and you can click once more. We got a little animation here that's not showing up. But if we do a little research here, when we look at how people actually make choices, very few people spend a lot of time trying to integrate and add up and say, okay, let me combine premium with out-of-pocket costs. What we've seen that people do, and psychologists have discovered this through what's called eye tracking studies. So they actually have people do this on a computer, and they put a little thing on their heads, or they have a little tool on the computer screen that can watch where your eyes go. And what they find is that when most people look at these comparisons, rather than comparing across the rows and trying to add up premiums and out-of-pockets, most people scan down one or another column and spend most of their time just comparing on one particular feature. So some people really focus on premiums, and other people really focus on either deductibles or out-of-pocket costs. And fairly few people can do a good job of really merging them together. All right, so if we go to the next slide here. So the question then becomes, all right, given that people have to make these potentially fairly consequential choices, how can we help them if, the typical thing would be to just pay attention to a feature and sort of guess, well, if I'm healthy, maybe I should pay attention to premium. And if I know I need a lot of care, maybe I should pay attention to out-of-pocket costs. What's really going to end up mattering for people's finances is the combination of both what you pay for the plan and what you pay out of pocket. And what some of my own research and research of others have found is that, if you do it the right way, people can potentially benefit from decision aids that help them. And the phrase we sometimes like to use here is frame the bet they're facing. Anytime you pay for an insurance plan, you can't know for sure what you're going to spend. It's going to cover part of your costs. It helps reduce that variability, but that also comes at a cost. And so one way to think about this is that in most cases, it would be helpful if we could more directly compare plans rather than just on their features, but on the final consequences. What's it going to mean in terms of money? And so you can think about the best case scenario. That's always going to be the case where you're not sick and you don't need any care, and you only end up paying the premium for your plan. Now, that might feel a little bit like a waste, right? I've paid this premium for a plan, but if you really think about it in terms of spending, the best off you're going to be is just paying the premium. Any additional out-of-pocket costs move you towards worse or middle cases. So if we think about the worst case, we can think about really major illnesses where you hit the maximum out-of-pockets. So in those cases, we want to combine the premium and those maximum out-of-pockets. And in the middle cases, we want to maybe find a scenario for something in the middle, like let's say a couple of specialist visits and an imaging study, and make that comparison. So if we go to the next slide, I'm going to show you another example here, and we're going to do another poll here in a second. So here's an example of two options that are similar to a couple of plans that are available here on the ACA exchange in Dane County, where we're located here in Madison. And so I've got two plans, plan A and B. You can see their different premiums and deductibles. And what I'd like you to think about is, which do you think you would choose for yourself if you had to choose? So let's go ahead and launch that poll.
All right, and Justin, this time we'll go ahead and give them about a full minute to decide. We had a couple people who were still deciding when we closed out last time, so we'll just give that a full minute this time. Yep. So we have about 45 seconds left. Also, I do apologize if you see a little gray bar up here at the top of the PowerPoint. That is my Zoom controls. They have this weird little feature that it overlays with a gray bar anytime I have the meeting controls up. So I am trying my best to keep that away, but during the polling session, I will have to have that present, but that will go away as soon as we advance to the next.
And Justin, I'm not sure if you saw in the chat that there were a little technical difficulties early on. Are there any points that you'd like to restate earlier that you feel like maybe would be important for us to hear again?
I think we're doing all right here. I think, basic idea that we want to think about to start from is, making a comparison best we can of the costs of plans where we think about both the premiums and the out-of-pockets rather than thinking about those separately. And we'll talk a little bit more about that here, and then we'll transition a bit to some of the other work. All right, so we are dead split as a group here. 50% chose A and 50% chose B. And I think that's not that surprising in the sense that this is actually kind of a difficult choice. It's not this one's no brainer. There's no dominated option here. But what I want to do now is show, well, what might it look like to help somebody frame the bet a little better here? So if you can click the next thing, Mike. So here's a version of a table that might help us frame the bet that we're making if we choose one plan or another. So what I have is 3 columns here: the best case where you don't need any care, a middle case where you need about $8,000 worth of care for the year, and a worst case where you've gotten very sick and you're going to hit the maximum out-of-pocket limit with either of these plans. And then what we've done is just added up the total premium and what your out-of-pocket spending would be in these 2 cases. And then we can take the differences. So what you can see in this case is that when you get the best case scenario, you're going to save $1,500 with option B. Okay. If though you end up in a kind of middle case, $8,000, maybe you need a small surgery, or you need some expensive imaging, you have maybe a visit to the ER, you might end up spending somewhere on the order of about $600 more with plan B. In both cases, you're going to end up spending a lot, right? We've got $10,000 of bills. So this is a hard situation. And if we go to the worst case, you're going to end up saving about $600 with option B. Okay. Now, so let's go ahead and launch a poll. This is going to be our last one. Let's just see, once we frame the bet, does anybody view this decision differently? So go ahead and tell us which one you think you'd choose after seeing framing the bet. And you might choose the same thing, or we might see a fairly strong shift one direction or the other. And I have no strong predictions of whether you're all going to change or not change here. So I'm actually quite interested to see.
All right, this time, since people have had an opportunity to take a second to look at both these plans, we'll give that just another 10 seconds to let people answer, and then we'll close that out.
And I did see one comment in the Q&A about not being able to see the items to make a choice. It may be on your screen, especially if you have 2 screens, that the poll question may pop up on a separate screen. So you might just want to look and see if you've got polls floating somewhere else. All right, so what we can see is that in our group, this did actually cause a bit of a shift. So looking at this framing the bet table, what we can see is that we had a modest shift. It's not overwhelming, but about 10% or so of people look like they've switched to B. And there might be a few people who also switched the other direction. But on net, we can see a little bit of movement. And I think that's just sort of a good example that, for most people, it's going to be fairly hard to absorb the typical thing we see, which is tables that show us features, and really translate that meaningfully into what does it really mean to compare the amount of money it would end up costing you. And so I think these sort of framing the bets are helpful. So if we can go to the next slide here, Mike. So key steps for doing this in practice, and we'll sort of skip through a little bit here. Healthcare.gov actually has some good tools for helping this. And I think we're going to see these in the second part. So I'm not going to belabor this point very much, but you can start by sort of focusing on the monthly premiums. Make sure you sort of multiply those by 12 so you can compare premiums to things like the maximum out-of-pocket limit. And then healthcare.gov has a couple of tools, including, I'll highlight the third one here, and we'll see this maybe a little bit when Sandy takes over, some cost and coverage examples that actually allow you to look at these out-of-pocket costs for sort of low, middle, and high spending possibilities for the year, and would make it much more possible to create this sort of comparison table for people. So if we go to the next slide. So there are some power and limits of these sort of decision aids. So the good thing is that decision aids can simplify these comparisons. They can really help us understand the cost consequences of different plans. But there is a bigger problem, and one we need to recognize before we focus solely on costs. And this is, Julius highlighted this phrase that I like, that the most cost-effective plan might not be the most health effective. And I see this as a little bit of a catch-22, that in a lot of cases, the high deductible might really help you save money. But if your reaction to the high deductible is then to not go to the doctor or fill your prescriptions, that money savings might end up costing you on the health end down the line. So if we go to the next slide, there's actually been a fair amount of research investigating this. So this is just a very quick slide about a study that was done at a company that had employer-sponsored care. But what they did is they shifted everybody from a very generous plan to a high deductible plan. But the interesting thing at this company is that they gave people a lot of money into a health savings account that in theory could have covered most of that rise of out-of-pocket costs. So they didn't really expose people to very much worse costs on the health cost side. But what they saw was that when they made this switch, people went to the doctor and accessed a lot less healthcare. So when people had high deductible plans, they accessed a lot less healthcare. Now, if all of that was sort of reductions in potentially wasteful spending, like questionable imaging studies for, minor low back pain or something, that would be a win potentially in the health econ world. But if you go to the next slide, Mike, what they really found was that these reductions went across the board for a bunch of care that is almost surely quite valuable. In particular, for instance, you can see there was a 48% reduction in fills for diabetes drugs and an 18% reduction for antidepressants. So it looked like people, even though they weren't really in a worse financial position, became very sensitive to costs once they had the high deductible in ways that were probably suboptimal for them. So if we go to the next slide, Mike. There's also been some studies of this with seniors who are on Medicare plans that have basically shown, and this was a clever study that exploited the fact that some seniors get paid on the second Wednesday of the month and some get paid on like the fourth Wednesday of the month. And they use the different timing of when people get paid to study when do seniors actually fill their prescription drugs. And what they found was that seniors who had very small copays for prescription drugs, like on the order of $5, were very sensitive to their pay date. So they filled most of their prescriptions on their pay dates. But seniors who didn't have to face any copay filled prescriptions all through the month. They weren't sensitive to their pay dates. And so what that meant was that the seniors who faced some copays were potentially delaying heart medicine and diabetes medicine, a whole bunch of other things for a week or so, waiting for their Social Security checks to come in. And that's sort of further evidence that being exposed to cost sharing can cause people to make decisions that may lead to kind of suboptimal health, partly potentially because they struggle to budget for those out-of-pocket costs, and maybe partly because there's that sort of psychological pain of having to pay out of pocket. So if we skip, go to the next one, Mike. I think let's just skip this one. Let's stay on this one. So, I think the important things from an enrollment assistant point of view are that it is important to draw attention to out-of-pocket costs when discussing total cost comparisons. So there needs to be a discussion of, okay, do you really understand what your trade-offs are here? You might save premium, but be exposed to more out-of-pocket costs. In terms of total money for the year, that might save you. But you also have to be ready that those premium savings maybe accrue every month with lower premium checks. But when you get hit by a high out-of-pocket cost, it may come all at once. And so helping people just sort of recognize that there's a budgeting problem here is important. And it may be valuable to discuss things like HSA options for people considering an HSA as one way of starting to think about whether they want to sort of set additional money aside for these things. So let's skip ahead, skip the next slide, Mike, and we'll kind of go to my wrap-up slide here. What I would summarize from kind of my takeaways here are that I think it's really helpful to help people frame the bet they're making, because most people aren't going to do a good job of trying to integrate both premiums and out-of-pocket costs. They're going to tend to focus on one or the other. And there are some good tools for doing the sort of scenarios that I showed in that one example on healthcare.gov. I think Sandy will show us a few of those. And we want, at the same time, not to be so completely focused on costs. We want people to recognize that ultimately the value of a plan also comes from their ability to get care. And each person has to sort of decide for themselves how they're going to react to the costs. So I think we want people to be aware of what the implications are, but also sort of help them recognize that, just choosing the plan that, a comparison says is going to save you money overall may not be the right choice for everyone. All right, so let me stop there and open it up to some questions through the Q&A here.
And Justin, while we're waiting for questions to come into the Q&A, I'd like to just swing back and comment on how your discussion of consumer behavior helps us understand in our work using examples, like examples of care costs, or as you're talking to me, maybe you've told me that you're a self-employed roofer. I can then use that information and that example to make a real life connection to you about, if you were carrying shingles up and you strained your back and needed to go and get an MRI, it might cost this. And then God forbid you fall off the roof, that might cost you this, and you might meet your out-of-pocket maximum as a result of that. And so this is that intersection between you sharing with us what consumers kind of see and understand about insurance, which is sometimes very little. And I think also a lot of people are really numbers adverse. They don't really know how to, as you say, frame the bet and look at the numbers and apply it to how care costs might impact them in their lives.
That's great. So we can see if we've got any questions. I'm happy to answer them now, but I'm also happy if we want to move and sort of see the kind of practical implication of some of this with Sandy. I can also be available to sort of chime in a little if some questions come out through that over time.
Justin, one more thing before we move to Sandy is I remember having a discussion with you and you commented that sometimes consumers don't trust the tools that are shared with them to help them make those decisions. And my comment to you as you were mentioning that healthcare.gov has tools is that I didn't trust them in the past. And I think they've really improved. And you showed me some ways to use the tools. And as we transition to Sandy, and we can, Kim, pull up that, or Mike, pull up that next slide, because Sandy's going to do a live walkthrough on healthcare.gov. Is I think Sandy has experienced working with this website so much over the years and working with consumers who are, kind of higher income and sometimes, or quite a few times over cost sharing income limit. And she's used some of these tools now, and she can share that she's actually found that they are trustworthy tools. I do see a couple of questions in the chat before we move on, Justin.
Yeah, so I see, Michael's got a good question here, sort of a question / comment, sort of highlighting that many consumers he works with have their plan choice dominated by their monthly budget constraint, and really think about that the premium doesn't offer any flexibility, whereas cost sharing may have some flexibility over time. You may be able to negotiate some small payments and other things. I think that's actually a really good point that, for somebody who really is struggling to budget, and I think a lot of, the clients you all work with are going to be in this situation because we're talking about really large amounts of money in a lot of cases for these out-of-pocket costs and premiums on the ACA plans, especially for people who aren't subsidized. Premiums really do have to be paid each month. If you don't pay those, you're going to lose that coverage. And that is a flexibility issue. Whereas cost sharing, most providers are going to, have some leeway of, if you can't get us the payment this month, you might pay your bill next month. You can work out a payment plan. And so I do think that's an important insight. And there's some good work suggesting that actually can be a fairly important thing for sort of pushing towards plans that don't have as much coverage, because there is this sort of like hidden coverage that comes from the ability to negotiate with providers. There's been some interesting, the New York Times actually in the last week or so had a piece on that, and sort of the debates between providers and the insurers and the government around, how important that kind of they use words like charity care and other things really is, and sort of what the appropriate amount is. But I think that's a good point. And then we had one other question from Carolyn here. Are there types of plans that seem to encourage people to use their health care? And right now on the research side, it's pretty early days for plans that are really customized towards trying to do things. But what we do see is a rise of plans. I think Julia mentioned these earlier, that are starting to recognize that people are sensitive to these costs. So they're trying to move away from what you'd call like the blunt instrument of a deductible, and towards plans that for care that we think is uniformly quite valuable, trying to have much lower or no copays for those things, and leave the copays for things that are a little bit more of a decision that somebody might have to make. Maybe some things that are a little bit more of an elective surgery, or maybe certain types of imaging and things. So there is some movement towards that. There hasn't been a lot of rigorous evaluation, but I think there are some reasons to think that those types of options may be important for certain people who want to access care, but know that they're going to struggle in the moment if they need it.
Thank you, Justin. And I just want to, while Sandy's getting ready to transition to her sharing screen, to underscore your comment about financial assistance applications for people who have what may be considered, they'd be underinsured. You've got one of those high deductible plans. And we always recommend, when we hear people have large bills at a hospital system, to apply for that financial assistance, because they will often offset some of your out-of-pocket costs when you've got those lower premium, high deductible plans and you're just strapped with a huge bill. So as Sandy gets ready to share her screen, and Mike, if you can enable her to do that, and she's doing that. And hi, Sandy. Sandy's on camera for right now, and you're muted, honey. As we get moving along here, I believe Sandy's going to turn off her camera, because then she can focus on the screen ahead of her. Sandy has been so generous. She's right in the middle of Medicare time right now, and we've really worked together so that she can tell her story and show the tools on healthcare.gov. And she's so experienced in walking people through plans when they don't have cost sharing as something that's going to help them offset costs. So Sandy, I'm going to switch it to you, and you can share how you start working with consumers on healthcare.gov, how you're assessing households and helping them walk through their plan selection choices.
Good morning, everybody. Hopefully you can see my screen and hear me okay.
You're good.
All right, excellent. So as Julia mentioned, she asked me to just go through some of the things that I would discuss with the client and how we would look at plans. Now, as an agent, I usually use a direct enrollment site. So I did have to refresh myself on healthcare.gov. So if you're seeing a new screen here, it did change from last week to this week. Of course, we just go to healthcare.gov, get coverage. We used to have a nice option right here that said see plans. That has changed with the upcoming new year. So if you type in plans, it will just bring you right back to where you can now see and put in options for 2022. Obviously, 2023 is not out there yet. So we will see when 2023 comes out that when you need to do 2022, especially if you have someone needing coverage for November or December, that we can still do that. You just have to make sure you click on the right link to get to those options. I am in Kaukauna, so I am going to use where our office is located as my zip code and county. I know many of you are throughout the state, so you might see some plan choices that are not common in your area, but we'll do our best to make this easy for you to understand. Julia had asked me to pick someone that had a higher income for the sake of showing something that you might not typically see. For those of you, especially working in the partnership, we know it's common to have people with limited incomes come in and ask for help. And when we have those limited incomes, very easy to look at those silver cost share reduction plans when they're under the 200% income level. But we're going to take a married self-employed couple They're not going to have any dependents at this time, and we're going to put them in their 40s. So we're going to take a 45-year-old male. He's not going to have any extra conditions going on, and a 46-year-old female. And then we're going to see what type of options we have. Always double check your information as you go through. Make sure that the information you're entering is accurate. When it comes to income, we're going to have to be sure that we can use numbers that are going to be a good representation of what they're going to have for actual income. If we're bringing someone in this time of the year, they might have a good idea where their earnings are for 2022. But when we make that transition to 2023, if they're self-employed, they haven't seen yet exactly how this year has ended. Sometimes it is difficult to estimate an income for 2023. So that you can help them through that by asking them, what does your year look like this year? What have you earned so far? Keep in mind, though, that we are using net profit or net loss. So we're not going to be counting their gross earnings when it is a self-employed person. So you're going to want to be sure that they are looking at their tax return, talking to their accountant, using the numbers that are going to be most accurate to give you that idea. If they have their tax returns, they're likely going to look at either their Schedule C or Schedule E for that net number to use. In our example, we're going to put them at $75,000. So some of you might say you don't have people come in with higher incomes very often, but fortunately I do see that. Now that we have this next screen, this is where your clients are going to say, oh, is that all I have to pay? Or if that's a high number, they panic, right? If they get $1,000 credit, they might panic and say, oh my gosh, I have to pay $1,000 a month. We need to explain to them this is the amount of advanced premium tax credit. The government is going to help pay for that insurance premium. They're going to pay that directly to the insurance carrier. So this amount will actually reduce the premium that they will need to pay when they do choose their plan. The easy part, right? Picking the plan. You can look at these definitions and details on your own. I'm just going to bring you right into the plan selections. They do have several built-in filters that we can use. We could look at ranging our monthly premium, our deductible. We can look at whether or not we want to enable a health savings account. We can enter providers, we can enter medications. So we can pick one particular insurance company. You can enter and change these as you need to. The other way that we can do this, piggybacking off what Justin talked about today, is we could actually enter in and estimate our total yearly cost. So we can look at is our client a low user of care, a medium user of care, or a high user of care? And so you're going to have discussion with your client about the level of care that they are using to put in your best guess here. And everybody's situation is going to be different, just like everybody's background is going to be different. So as you're meeting with your clients, any information that you can get is going to be helpful. I like to ask them about their previous insurance. What do you have for coverage now? What did you have? What did you like about that coverage? What didn't you like? Because that's where you're going to learn, oh my gosh, I had a plan. It had such a big deductible. It never paid for anything. And then you're going to know, if I come out and say, let's look at a high deductible health plan, we might put them in a panic right away. So we want to make sure that we're asking questions, getting information, what's important to them, and then using that information to move us through. So in this example today, we are going to have one person who has frequent doctor visits, using prescription medications, may end up with a hospital visit. And we are going to pick the other person as being generally healthy, few doctor visits, minimal care. So it will now bring in a total estimated yearly cost. We can use this information as a tool to guide us. Like Justin mentioned, sometimes people are going to focus just on that lowest premium, which is how our plans are sorted automatically. He mentioned that they might want to do it based on lowest deductible. So we could choose that option as well. And then it's going to bring in a plan that's not going to have any deductible. Or we could look at using our estimated yearly cost. And I'm going to use that tool today to focus on because of the previous training. So if we were to use that estimated yearly cost, you may find it interesting that the first plan that popped up is a high deductible health plan, and it is HSA eligible, health savings account eligible. The thing that you need to know though is, what does that mean? If I am new to the insurance world and I'm not familiar with a health savings account, I'm going to look to you to give me some guidance on that. So we need to be able to have some information that we can explain to them about that health savings account. By depositing money into an account which they can set up at their own bank or credit union, they can get a tax deduction by putting money into that account that is specific for medical expenses, qualified IRS qualified expenses such as medical, vision, dental. So they want to be sure that they are aware this money is now going to be earmarked. I can't use it to buy a new furnace or buy new windows without a penalty. So if I'm going to put money into this account, it is with the intention of using it for my medical expenses, or with the intent that I'm going to let it grow and use it as a way to prepare for my later years and use it sort of like a retirement account. I might be generally healthy, not using medical care, so I might want to get that money into the account and let it grow to use to cover my expenses when I'm on Medicare after I turn age 65. So the HSA, in this example, my self-employed people, we are going to say that in our discussion, they are familiar with health savings accounts. And with that $75,000 earning, they do have some assets that they could use to fund that health savings account if they choose this option. So if they were going to put money into the health savings account, some of you may know this, but they would be able to go back and lower their income based on the amount they're going to fund that health savings account with. If we have a husband-wife who both choose to pick a health savings account, high deductible health plan, HSA eligible, right? They could deposit this year in 2022 up to $7,300 for a family contribution for the two of them, both of them being under age 55. If they were going to put in, let's say $7,000 for easy math, we can lower this income down to $6,800 or $68,000, I apologize. And by doing that, we notice that our tax credit just went up. It went from $359 to $422. So they now have more money that is going to be applied toward their premium, resulting in a lower premium. So now this plan has a higher tax credit. The full premium did not change, but the net premium did. So if you're doing the application, because obviously this is not the application, you would enter that information in After, and correct me if I'm wrong, Julia, because again, I use a direct enrollment site. After you calculate the eligibility, you do, or I apologize, when you're in the actual application, when you enter the income that they earn, yes, thank you. You then have underneath there other deductions. And so you would want to enter that $7,000 in there as an other deduction. If you want to split it and put half under the spouse, you could do so. You could show it under one. It's not really going to matter. Either way, they could do that $7,000 deduction. Because our person is self-employed, they may also be doing their own IRA, a whole nother area to consider, but it is another way that they can lower income, take a deduction by contributing to their retirement account because they don't have a 401k if they're self-employed. So these are things to consider. Again, ultimately your client's responsibility to help you determine that income and the amount they're going to apply to those deductions, but they can work with their accountants and give you the numbers that you're going to need to put into those screens or fields to get that to calculate out correctly.
Sandy, can I pause you here and make a comment quick?
Yes.
In that income deduction section in healthcare.gov, crazily, the description does not say you can use this to deduct HSA contributions. It talks about school expenses or contributions to an IRA. So I just wanted to restate that you can use that section to account for a health savings account that someone plans to use. And what happens then, Sandy, if you don't actually make that contribution, or if you don't know to add it into the application, what happens then at tax time? Will you still maybe get more APTC back if you didn't claim that income deduction?
Correct. So if your income comes in higher than estimated, or if we estimate high, and then we do make that deduction, when we submit that tax return, they are going to adjust and base the calculations on the actual income. And if your income does come in lower, you will get those additional credits. It will come as a tax refund at that time. So for people that are concerned about having to pay in, you can certainly leave that amount off. They can always, or if they're uncertain whether they're going to be putting money into that HSA, they can always do that and still get the benefit or the credit from that deduction for either an IRA or the health savings account. Keep in mind, though, they can only do the health savings account if they have a plan that is HSA eligible. So fortunately, they give us a hint right here on the side, eligible for a health savings account. The other hint is usually in the name. So for this plan, HDHP, high deductible health plan, if we look at the next one, it says specifically HSA. The next one, HSA. And just to bring you back to our filters and our tools, we put in estimated yearly cost. How many of you were expecting to see the first 3 plans from 3 different carriers to all be HSA eligible? We took someone that had high usage, so we would expect them possibly to meet their out-of-pockets. And if you look at the plan details, the nice part about these tools is it will break it out so you can clearly see the individual total versus the family total. The individual only has to meet their total before the plan pays 100%. There's no charge after deductible. So this $7,000 max out of pocket, most of you might be thinking, well, usually it's $8,700. It is $8,700 if it is not HSA eligible. That max out of pocket is limited on the high deductible health plans. The government controls those limits and amounts, just like they determine the max that you can contribute to the HSA. So for a person who is a high user of care, that $8,700 is now down to $7,000 for a max out of pocket. So as Justin mentioned, sometimes we don't look at all the pieces and realize there is some additional savings by doing this, plus by putting the money into the health savings account, we now get a tax deduction and we can take that money back out and use it to pay the providers that we are receiving care from. So if we were going to do a comparison, you would certainly want to look at where is this person going to seek care? Who are their doctors? What medications do they have? Are there name brand medications that we need to be concerned about being on a formulary? Perhaps this person is on a name brand blood thinner like Xarelto. We're going to be careful. We don't want to put in a liquid. If it's a tablet, make sure we're looking at the strength, the medication that we actually need. We also could put in doctors. Now, if you notice, I didn't put it in there. You can click here and put it in. You could go to the filters and put it in. I'm going to use local. We have Kaukauna Clinic. I'm going to take, actually, I'm going to just take a local doctor at the Kaukauna Clinic for the sake of putting someone in there. It's an independent clinic that does affiliate with several hospitals in our area. So if this person did use a clinic of that nature, they'd have options to look at several plans based on hospital choice. Perhaps this person also has a cardiologist because he's on a blood thinner. So we could bring in a specialist as well in our surrounding area. Be sure when you are picking your doctor that the location matches your area, because sometimes what we see happen is we might get somebody in the area. We might see a common name, but it might be in a town 3 counties over, and that will not mean that they have access in our area. So now we can see by the green check marks whether or not it is in the plan. Some do not list. It does tell me they were added. To then find out you would want to go, what would you do? Oh my gosh, I want this carrier, but now I don't know who is in that network. How do I get to that? Couple ways you could do it. We could run these alongside each other in a comparison, and then we can bring it up under our plan documents. We have our summary, our plan brochure, our provider directory, and our list of covered drugs. So if you like this tool better, you can go direct if you know you want a particular carrier, or you can use your screen as a comparison as well. And I know, Julia, you had, so in this case, we're going to just say our member is going to pick a high deductible health plan. They're going to go to their local bank or credit union, set up their HSA account, and deposit throughout the year as they so choose. That would make it an easy choice for us. But what if it's not so easy, right? What if this person told me, I don't want a high deductible? Or what if we want the high deductible health plan for the husband, the high user of care, but we don't want the high deductible plan for the spouse? You can split them. I do not have access to a tool on this site that will do it, but when you are in the application on healthcare.gov, after you run the eligibility, then you can choose if you want 1 group or 2 groups. And at that point, you can divide and go back through and see your plan choices to help pick a plan for the husband and then a plan for the wife. Because what if our wife
Sandy,
said, Yep.
yeah, let's underscore that, because I've seen that happen a couple of times where husband has healthcare needs require him to go to a certain hospital system that he's been getting treated, for something major, but wife loves her provider, her gynecologist, or her primary care doctor who's another system. What do you do then?
So then we can split them out. And in this example that we had 2 different methods anyhow, but she's a low user of care, you might come back not necessarily to lowest premium, but I'm going to bring in a filter because I want to take just one carrier. So if we had, and I'm just going to pick the first one that popped up, Network Health. And if we were to look at just Network Health, because we have our, well, we're going to assume these are her doctors too, even though we know that those were really based on our higher user of care. But let's just say our doctors are in the network that she wants. What are we going to look at? How do we pick a plan? We could take this low plan. In our discussion, I'm going to find out, is she looking to have co-pays? Is she comfortable with that deductible? If she's already said, nope, I don't like that deductible. This plan has a high deductible. It is not HSA eligible. So they could not contribute to the health savings account. And it does not have any initial copay showing up here for medications. Maybe she has a couple generic drugs that she wants some copays for. So this one, I can see already I don't have a copay here, not going to work. Now I do see some copays, so I might want to look at this option. I have a 0 deductible plan with copays, and I have that high deductible health plan. I'll bring it in, but not for the sake of necessarily using if they already told me they don't want high deductible. So now I do see my 3 choices. My premiums, my net premium after the credit, $322, $331, $346, not a lot of difference here. So how do the plans differ? We have, oh, I can't get to my drop down here. Hang on, guys. Gotta move that. Okay. We have our star ratings, which we can discuss how well are the plans utilizing in the services they offer. The star ratings are an important piece to compare plans. We have plan documents, which I already showed you, but this is the piece that I like. I like the cost for medical care because now I can see side by side, what is it really going to cost? So if my client tells me that I see my family doctor once a year for a wellness visit. At that time, they do some labs and they renew my medications. So if it's a wellness visit as we know, has to be billed as a wellness visit. We cannot have other services occurring at that same time that would be diagnostic. An example of that, if I fell the day before, jammed my wrist, and I asked the doctor to look at my wrist while I'm there, it's no longer a wellness visit, it's now diagnostic. So if that would happen, they would have a copay. In this example, for a primary care doctor, it's the same, 55 or 55. We have a specialist, 110, 150. We have labs, 55 versus 75. But for imaging, we have copay after deductible or a set copay. So
Sandy, can I interrupt? Will you remind us again, which one of these is the 0 deductible
sure.
plan?
The middle one. I'll go
The
back.
middle one. So those
The
0
middle one.
deductible plans, which I've kind of likened to an a la carte menu. There's a copay assigned with everything that you do, but some of the copays could be higher.
Correct. Correct. And so now we could show them some options. And I'm going to just run back. Here's the bad part when I open all these up, right? We get too big of a spread. But we're not looking at a whole lot of difference in premium, less than $10 a month. And now they can decide, do they want this big deductible, which would come into play if I had a hospitalization or a surgery, or do they want to have a copay to minimize that risk if they're a low user of care? Keep in mind, these numbers we're using a high and a low. I didn't go back and change it, which I could and should, but to save time. So now we can look at these options and decide if I had to have outpatient surgery, it's going to my deductible. Here I have a copay. So the plans are set up very differently. So sometimes this side by side is a nice tool for the client to make a better decision based on their likes, because we all have a different way of shopping for our plans. We all have a different health history. We all have a different willingness to take on risk. If I'm a low risk taker, I might look at those copays and say, that gives me peace of mind. I can sleep better at night knowing that I'm going to have a set dollar amount than having to worry about that $7,700 deductible. You might have another person who's a low risk taker, health history, clean as a whistle, family history good. They might have some money in the bank, and they might look at this and say, you know what? I'd rather save my premium dollars and take my chance. Especially if they're coming in with a couple months left to the year, they might say, I only got 3 months left this year. I'll take this plan this year and look at them again next year. But you're going to find as you give choices, show options, everybody looks at it a little differently. And the nice part is there's no right or wrong answer here. It's what allows them to sleep at night and gives them peace of mind, because each of us come from a different place. So by asking questions, learning more about what they would prefer and what they've had in the past, what they've liked, what they didn't like, that can help you in moving through this choice. Julia, did you want me to go through the one other example that we talked about prior to this?
Can we take a break and let me ask some questions that I'm seeing here in the Q&A, and then we do want to catch your last example for sure. How does splitting a family into groups affect the APTC distribution?
So I'm going to tell you that I don't know how they divide behind the scenes, but it will divide it. And so based on their premium and their age, they will divide. But let's say you go through and you pick the husband, and I will tell you this, it will adjust and use all the APTC credits. So if you pick a low plan for the first person that doesn't use all the credits, let's say that they picked that lowest price bronze plan, and we know the credits are based on the second lowest price silver plan. So they'll have some credit overflow. Any additional credits that that person didn't use does roll to the other spouse. So once you pick a plan for the second person and allow it to recalculate, it will adjust accordingly. So that is the good news. You will not lose out on any of your credits, but they both will get their appropriate amount. If they pick a plan higher than the amount that is preset for them, they would pay the difference. And if it's lower, it will roll to the other family member. Does that answer the question?
Yes, thank you. And here's another question of some of the plans that we're seeing list dental and vision in their names, that there's dental and vision, especially dental offered to adults in those plans.
So there are. So again, if we continue down our list on our cost, it will get into routine eye exam for adults, no charge. You will see your dental as well. And so the key is to use these drop downs to look what is there. It's especially important for your prescription coverage if they're looking for co-pays. So this was a low premium bronze plan. We have deductibles here, you know, rather than co-pays, but use these drop downs, take advantage of the information that's in there. Most of this time of year, I'm going to tell you, most of the bugs have been corrected. In the beginning of the new season, sometimes you might find that, I know Julie asked me, do I trust this information? And that's where I'm going with this statement is yes, I do, especially mid-year and beyond, because the bugs have been taken out. When we first start in the fall, we may see a few little glitches until if there's something in there wrong. I personally do reach out to the insurance carriers and say, just so you know, this isn't matching what's on your summary of benefits, and clarify what's correct, and then they can go back and make changes. But use all these drop downs because it's going to give you all these extra details. Do we have copays for mental behavioral? Do I have coverage for therapies? It's all out there.
Sandy, before we run out of time, can you show us the example of a household that qualifies for that highest tier of cost sharing? So they're in that 73% actuarial value, where technically they qualify for extra silver savings, but you have something to show us about that.
So one of the things that Julie and I had gone through was, if we lower this income and they come in between 200 and 250%, of course, the amount of tax credit does increase significantly because we lowered their income. And we do get this lovely button telling us, look at silver plans. We want to look at silver plans because we do get cost share reduction. So when we bring those silver plans in, I'm also going to do this so that because this is the example I used for her. So we have this lovely silver 73% coming in between 200 and 250% federal poverty level. And then we're also going to use a zero, and I'm sorry for going so fast here, a zero deductible plan, because this was something that to me, I find very interesting. So if I have that low user of care, not going to work with a heavy user of care, but if I have a low user of care coming in that bracket, we have the silver plan at $105 a month approximately, and we have the zero deductible bronze plan coming in just under $25 a month. Significant difference, $80 a month in premium. We do have a deductible on that silver plan. Your deductible typically is lab, x-ray, surgeries, and hospitalizations. So you look at what are the services you're going to use. Are you planning to have any upcoming surgeries versus this zero deductible? Now our out-of-pockets, $69.50 per person or $8,700. Keep in mind, if it's a family, two times max. But if we look at the services that you might actually use, if they're a low user of care, and if they say, I go see my family doctor a couple times, I want to go back so you can see this again. We have the zero deductible on the right, the silver cost share reduction on the left. If I'm seeing my family doctor for that annual visit, they run a couple labs, I maybe have a couple generic meds. That's my normal year, other than my mammogram, those types of things if it's a female. We have $50 copay for the primary care versus $15 copay. There is a big difference if your health changes and you do need a specialist, but if we're looking at a normal year of what their history has been, we look at labs, we have deductible versus a $50 copay. And if we go down to medication, we have a $15 copay versus $25 copay. So if we look at what Justin was talking about and we look at what is our actual cost, if we have two medications, our difference here at best is $20 a month. We know that the deductible for the labs is going to be more than the copay in most cases. And when we look at the copay for the primary care doctor, we are lower on the right than the left. So if we did a graph and marked those out, plus added in the premium, your silver plan may or may not be the plan that your client really is going to take.
I
Thoughts
think
on
that's
that?
such a great example, Sandy. That kind of blew me away. In our last minutes, can I ask a couple more questions that I'm seeing here in the chat?
Absolutely.
Here's a good example of, we're seeing a lot of people retiring in the mid to late year. And if you're especially a higher income household, are there times where it makes sense to continue on with your COBRA coverage for the remainder of this year in which you may have worked some, and then maybe look at the marketplace in the following year when you no longer have your earned income?
Definitely. Depending on their earnings, I do have several clients that have COBRA plans right now that will be shopping in November for January 1st. And the reason you look at that, we have to ask, and I do when I have a retiree or anybody who's leaving an employer plan, I do ask them, have you met your out-of-pockets? Because if I've already met my deductible and my max out-of-pocket, I now have to do the math, right? If I'm coming off mid-year and I have 6 months of premium on a COBRA plan, and if it's an individual, it might be $500-600 a month versus taking on the new risk of $7,000 on an HSA eligible plan versus $8,700 on a non-HS eligible plan. Is my $600 for 6 months at $3,600 going to make more sense than taking on a new $8,700 risk? And so that's what I would do that situation with all of them. I do ask them to gather that information up, and then we look at those scenarios. But it is something of importance to make sure that we're checking. A few years back, COBRA did not make a lot of sense, but I'm going to tell you this last year or two, we have seen COBRA plans that have been priced better or made more sense based on income for those people who are in that higher earning bracket.
Yeah, thank you. That's such good advice. There's a couple of questions on self-employed income. Would it be suffice to say, rather than digging into deep, that it's really a good idea, especially for us who are not, we're not tax experts, we're not financial advisors, is to steer people back to their financial person or someone who helps them do their taxes to understand what kind of income we need to count in the healthcare.gov application?
Definitely. If they are self-employed, they often are working with an accountant, and that accountant can help lay that out. If you do look at the income breakdown when you get into the application, it is broke out just like it is on a tax return, where it's showing rents and royalties, it's showing dividends, interest, capital gains. And that's an important piece too, as you see these retirees. If they're preparing to retire, they have already built up some assets, hopefully, to allow them to retire. Are they getting dividends, interest, capital gains? Some people do have some high numbers that they're getting on those 1099s at tax time. And again, I tell all my clients, if I'm meeting with them, I ask them to bring in their most recent tax return. Now, my situation is a little different because I do work in a financial advisor facility here. So we do have people that can advise us. I have 2 accountants that I call on a regular basis when I have questions to help advise me when I get stuck. So one thing, those relationships like Julia talked about that we develop, those are so important to help you. So look even at if you use an accountant yourself, are they willing to help out? Do they work with new marketplace clients? I have a couple accountants that,
Sandy, you're kind of cutting out, but I'm also seeing we're really at time. Honestly, we could keep you and Justin on the line all day long to guide us through this conversation. It's so valuable. If you'll stop sharing your screen so that I can have everybody's faces back on, so we can thank both you and Justin for all of your overview of consumer behavior, and Sandy for helping us see the tools that we can use on healthcare.gov. This was a great session. Both Justin and Sandy's information is listed in the PowerPoint if you want to reach out and make friends. And do make friends in your regional enrollment network with agents. They've been so instrumental to us over the years. Thank you both for participating. And Allison, I'm going to turn it back to you.
Thank you so much. I totally agree. Man, we could have just kept going with this session. So much really valuable information. And thank you, Julia. And thank you, presenters, for being so calm and cool under pressure. The technical difficulties wouldn't be a conference without them. So Congratulations. It was your session. And we're going to take a break here. We'll be back at 10:45 for our next session on outreach. Thank you all. All right, we are here at 10:45. Welcome back, everybody. We are going to go ahead and get started. Really excited to introduce this next session on outreach, and the panelists who will be speaking just to provide a wealth of expertise that they have to all of you. And it's being led by our moderator, Cheryl Isabel. Cheryl is the Milwaukee Community Engagement Lead with Covering Wisconsin. So take it away, Cheryl. You might be on mute there, Cheryl.
Sorry about that, everybody. Good morning, everybody. Again, I'm Cheryl Isabel, the Milwaukee Community Engagement Lead with Covering Wisconsin. And this morning, we are going to talk a lot about the outreach process, getting into our communities, connecting our communities. And we're happy to have with you three very amazing panelists that are going to give us a walkthrough of the outreach process and how that all gets started before engaging with our community members. I have with me this morning my co-host, Kirk Moore, who is also a navigator with Covering Wisconsin. And we're just going to get started right now with the presentation. Kirk, next slide. Thank you, Kurt. So now, and when we're talking about outreach, we just want to take a look at what does that look like? What does outreach look like? And it's part of sharing personalized outreach cards with local community partners, posting flyers and including outreach cards in backpacks, back to school events, posting our events and community information and your organizational information on social media, and encouraging partners to follow and reshare your posts too. It also involves working with partners to get articles or ads out into the community in a local newspaper or newsletter, and also attending community events or hosting them on your own. Next slide, Kurt. So outreach materials that Covering Wisconsin has for this year's open enrollment are new designs available for each and every one of your outreach campaigns. And these outreach materials are brought to you and be able to disperse in English and Spanish. They're ready to use social media graphics and videos, downloadable to print outreach cards and flyers. And just so you know, you can order these from Covering Wisconsin and by going in and searching and looking on our website at coveringwisconsin.org's toolkits. Next slide, Kurt. Now, as far as we have partner toolkits available as well, and they come with digital and other media formats, preferences for O&E outreach campaigns. Some of these digital medias can be found on wiscover.com, specifically for social media graphics and post text in English, Spanish, and or Hmong. Additional graphics can be also ordered for email signature graphics and social media headers, flyers, press release templates, and videos. And these are some examples of outreach materials that can be found through OCI, and they will be coming soon, preferably before open enrollment. Next slide, Kurt. Also, you can have your toolkit availabilities through DHS for continuation and preparing for our consumers for the impending PHE end and Medicaid unwinding. These can be found, as you can see here, on the DHS website through their COVID unwinding toolkit. And again, they're ready to use flyers, social media tools, outreach tools. Some can be customized to your organization's form information. So you can also come through Covering Wisconsin for that. In other words, if you have a company logo for passing out these materials at outreach events, you can contact Covering Wisconsin and we can have those logos added to these updated flyers and postcards. Next slide, Kurt. Other helpful media accounts to follow for easy ways to repost, spread the word. If your organization uses social media, you can follow and repost to spread the word through these organizations listed: Covering Wisconsin, Wisconsin Office of the Commissioner of Insurance, DHS, as well as healthcare.gov. And that's for your social media reposting, and we encourage you to do that. Next slide, Kurt. And then Covering Wisconsin also provides how-to sheets. These how-to sheets are available for educating consumers that are consumer tested and easy to read and understand. And you can visit the complete library of educational materials covering all the counties in Wisconsin. You can tailor these materials to use to display that fit your target audience that you're outreaching to. Next slide, Kurt. And then finally, Covering Wisconsin has reinvigorated the enrollment networks. And we have our enrollment networks in all 72 counties. We currently have about 9 regions throughout Wisconsin with 8 coordinators. And these networks are managed by Caroline Gomez-Tom, who is our enrollment network and accessibility manager. And you can find this map here on the Covering Wisconsin site. If you have a need to reach out to any of these regional enrollment networks for questions on outreach and any work that you're doing in your community, you can click on any one of these regions and it'll list the contact persons to reach out to for the Northeast region, the Western region, Central. And we also have a Latina enrollment network that covers the entire state as well. And Kurt is actually one of the coordinators of the Northeast region. So Kurt, maybe you could just share briefly with the audience a little bit about what your work entails.
Sure. So I know you've all heard about this in the last 4 days. I just want to bring this down to a regional level. Obviously, there's a lot of good reasons to be in a REN. We not only bring together other assisters, but also in my REN, at least, we're including some insurers as well as providers, and also transitional assisters like the ADRCs, Elder Services, and actually have had a buy-in from all the income maintenance organizations. So we're bringing a lot of people together to be able to work with disseminating information as far as training, policy updates, obviously the networking, and then some outreach coordination. It also, the REN gives you an opportunity to, on a regional level, have a voice on the statewide level. As we all know, that I think Mike and I, my counterpart from the West, can tell you, sometimes the people up north don't necessarily maybe agree or think like the people in like you in Madison and Milwaukee. And it gives us a chance to be a voice on a statewide level. So that's our plug to hopefully get you involved and hopefully contact either us or Caroline at the people listed and hopefully join up.
Thank you for sharing that, Kirk. And I'm sure that all of the navigators and assisters that are joining with us on this conference will find it very useful to reach out to any one of the coordinators listed in this enrollment network to help support their work and just join and just continue to get the updates to keep them aware of various changes and how to reach out to consumers in their given areas. Thank you again so much. So now I have the pleasure of actually introducing to you, next slide, please, our panelists that are going to be sharing with this audience their wealth of knowledge, how they go about their outreach practices. And with that, I'm going to introduce to you, first of all, Cheryl McCarter, who is the Program Coordinator, Community Health Access Program with CHAP, the City of Milwaukee Health Department. Cheryl is the Program Coordinator for CHAP, City of Community Health Access Program with the City of Milwaukee Health Department. She started working for the City of Milwaukee 15 months ago and became the coordinator 9 months ago. Ms. McCarter has a background in healthcare. Ms. McCarter worked as an income maintenance worker for the state of Wisconsin for 9.5 years before transitioning into her current role. Outside of her role with the health department, she helps to run a nonprofit agency with her husband to provide needed resources to the community. So Cheryl is an avid, robust community outreach individual that wants to get information into the hands of all community members and consumers about healthcare and or any of the other social determinants that challenge our community members. And then we have Lindsey Schwarz-Nichols from LaCrosse County Health Department. Lindsey Schwarz-Nichols is a social worker at the LaCrosse County Health Department, where for the past 20 years, she has been helping community members in need navigate community resources, programming, and services. Lindsey oversees Badger Care Outreach for LaCrosse County and coordinates the Western Regional Enrollment Network. Lindsey works with over 200 people per year, providing education and helping them gain or maintain health insurance benefits. She earned her BS in sociology with a minor in Native American and rural social work with an emphasis in social work from the University of Wisconsin-Stevens-Point. We welcome Lindsey to share all of her wealth of knowledge to this group. And then finally, we have Vanessa Silva. Vanessa is the bilingual benefits manager for Family Health Center of Marshfield. Vanessa has worked with Family Health Center of Marshfield for about 4 years, 3 years as a benefit coordinator and bilingual certified application counselor, and about a year as a bilingual navigator. She's been a liaison between Family Health Center and many different organizations and school districts to raise awareness about health coverage, with a specific focus on the Hispanic community. She actively collaborates with fellow navigators at the Hmong and Hispanic Communication Network, including through a weekly video cast called Salud y Bienestar, Wellness and Health. The podcast invites guest speakers from different organizations to offer resources ranging from healthcare, human services, immigration, financial, educational, and social programs. Welcome, Cheryl, Lindsey, and Vanessa. Next slide. So we're going to start out our outreach and have our panelists share the outreach best practices for connecting our communities with this first question. And those questions are, what are the primary ways you engage in outreach? And I just want to remind the audience that if you have questions, please feel free to put them in the Q&A portion of your computer screens, and then we'll come back and we'll get those questions answered. And we are going to start with Cheryl McCarter. Next, please. I'm sorry, we're going to start with Vanessa. I'm sorry, Vanessa.
Thank you, Cheryl. For some reason, I cannot present my video, but anyway, I feel honored to be here today, and thank you so very much for the opportunity. I am a bilingual navigator working with Family Health Center of Marshfield, and Family Health Center is a community health program. We have a prepaid health services program, and our members have access to preventive and specialty care, dental and pharmacy services. We also have a dental financial assistance at our 10 different locations. We also have an AODA program, an alcohol and other drug abuse program, not only to deliver medical care, but we have a coordination team that assists on getting patients and their families connected to different resources, employment opportunities, financial advice, counseling, and so much more. We are going through an expansion phase right now, and we are acquiring our own medical clinics and mobile units. We also have a health insurance navigator services, and it's been exciting, all the services we can provide. Next slide, please. And talking about outreach and education. So we are a group of 4 navigators, including my manager, and 2 of my fellow coworker navigators, Tammy and Alicia, reach a high volume of applications each year. We go to community events. We use the Covering Wisconsin how-to sheets and flyers because they are great. And but talking about myself, as Cheryl mentioned, I am part of a video cast that is targeted to the Hispanic community. It's called Salud y Bienestar, Wellness and Health. And it was not my idea. It's an H2N initiative, the Hmong and Hispanic Communication Network under Mariana Zavala, and she's a fellow navigator. We started talking about open enrollment last year, and it's been exciting for me to now be part of the team of the video cast. I am in charge of reaching out to different organizations and agencies just to invite them to the video cast. And we do it all in Spanish just to make Hispanics aware of the many resources we have in the community. In every sessions, we talk about healthcare coverage and community resources. We broadcast on Facebook, Twitter, and YouTube with the help of a local Hispanic digital newspaper, and it's been great. It's just been a great experience. Also, I mean, networking with the school districts, reaching out to mental health navigators, school social workers, nurses, just to let them know about the Medicaid unwinding and helping their special needs students who have Badger Care, and some of the services they receive at school it's covered by Badger Care. So that's how I enter, talking about health coverage with the school districts. And I'm very pleased to see that my flyers and information, they're part of the school registration events. So it's been great. We connect to county programs, retired community agencies, family-oriented organizations like the Marshfield Family Resource Center, Parks and Rec, community centers for the elderly. It's been great. So, and of course, I mean, all of us, the 4 of us do this, and this is how we conduct our outreach. So we will transition to Lindsey. Thank you.
Good morning, everybody. I too am very excited to be here to share what we have been doing in LaCrosse. Just to kind of give a little background, our health department in LaCrosse County employs about 50 people across various sections. So as of January, we went ahead and restructured our sections to be more of the pillars, to be family health, access to care, environmental health, and our laboratory, as well as chronic disease, injury prevention, and our administration. And we do our outreach across all of these sections. And it's been interesting as we've employed a few more staff members over the past about 9 months. Something that is unique I have found is that we are co-located in the same building as our Human Services Department, which then houses our, is like our home base, our seat for our Economic Support Consortia. So we are in the same space, separated by a floor, and have easy access to our economic support staff. Another thing is that I am the contact. So if you are in the Western region, Buffalo, Clark, Jackson, LaCrosse, Monroe, Pepin, Trempealeau, or Vernon, please reach out to me so we can go ahead and get you connected to our regional enrollment network. Next slide. Primarily what I do at the health department is forward health outreach. So like Cheryl had mentioned at the beginning, I have been at the health department. I just started 21 years in July. One of the first things that I got to do when I came to the health department was be introduced to the concept of covering kids and families, which ultimately was funded by Robert Wood Johnson. We were one of the initial pilots. So we have worked with covering Wisconsin for the past 20 years. So with our forward health outreach, like what guides our work? We have our community health assessment, and then we've recently done our CHIP, our community health improvement plan. And the top 3 things that came to the top for focuses currently are behavioral health, environmental, safe environment, so housing, food, physical activity, and access to care. And as you can tell, health insurance and resources, public benefits can tie into all 3 of those different areas. Working in a health department the past few years has been challenging, and we have had a lot of changes in the past 6 months. For almost 2 years, I was pretty much pulled from the duties that I had typically done and reassigned to the COVID response, working in pandemic work. But in the past 6 months or so, we have all transitioned back to our daily operations, and we are really trying to get back to those connections with our community members and our community partners. Some of the things that were very challenging during that pandemic time were that many of us were working from home, so we didn't have that one-on-one contact with clients. When I worked in the office all the time, I was embedded in the WIC program in our family health section. So when somebody came in for a WIC appointment, we would go ahead and they would just give me a call or walk down and say, hey, I have a new pregnant woman who needs help with applying for Badger Care. She doesn't have any insurance. And so it has posed some barriers, but we've worked through them. Even though WIC is still remote, we are still working together to go ahead and help with that one-on-one application assistance and getting people connected. But what it has really shown me is that the importance of relationships has been phenomenal, like to go ahead and connect with people that you haven't talked to in the past 2 years and to bring them back to the table. And that's what we did at our first regional enrollment network meeting, is to bring people back to the table. We had almost 80 people attend a training session to get people back on the same page and to start moving forward together. I'm going to transition it over to Cheryl.
Hello, Cheryl McCarter. As Cheryl Isabel stated to you, I am very happy to be here. Thank you for the invitation. We here at Community Health Access Program, the CHAP program, we are based out of the Maternal Health Division of the City of Milwaukee Health Department. So CHAPS helps community members understand their options as far as low and healthcare options for insurance, whether it's applying for Badger Care through the state of Wisconsin or whether it's applying for the marketplace. We also help people with things such as the family planning only services and food share and childcare. Transitioning from the state of Wisconsin, being an income maintenance specialist worker, it has been a different change for me. I was used to people coming in and seeing me to now having to go out and meet the people where they are. So helping them find health insurance plans that fit their needs or their budgets has been a change for me. I was so used to doing everything with the state and just assisting them with state insurance that the only time I seen anything or anybody looking for anything with marketplace was during open enrollment. Helping people connect to other programs or public programs like TANF or any other resources they might need, maybe somewhere that they can find a food pantry, things like that has been something different for me, even though I was doing it on my own outside of work. So transitioning from the state, as I said, has been a total change. During COVID, where nobody was seeing each other, as Cheryl explained to you, I was working with my own private 501c3 nonprofit, and we were helping getting people food wherever they needed it at. And during COVID is when I changed over to the city of Milwaukee and had to come back into an office because I was like Vanessa, where I didn't see anybody. Didn't see anybody for a year and a half, and walking back into the office and seeing people has been a big change. So working through the problems in the application process, whether it's helping people complete renewals or maybe needs to turn in verification, has been something different. Well, the same thing for me, but a little different. Next slide, please. So we have a staff right now of 5 people, including myself, located here at the Southside Health Clinic in Milwaukee and also at the Keening Health Clinic. Our remote services are based off of things such as us going into libraries, or we might be working at some place like a health clinic of some sort. So there is some, how should I say it? Outstation health places that we might go to, or a food pantry, instead of remote services, and assist people to see if they have health care, explain to them how they can get health care, or just see what other help they may need. So we make ourselves known in the community by doing community events such as health fairs. We might show up at anything. We have been at resource fairs. We have been at baby showers. We have also attended things like I said, just a food pantry that is open every week, but we might show up every other week, see if we can help, see if we can maybe assist them on a problem they may have. We have partners located across the city that we might show up at an event for them. And we use different sources of outreach to reach people, such as the resource fair we attended in August. We were working with a radio station, and since then have gained partnerships with them. Social media, we're not as big on, but we definitely have others that help us get the word out. Next slide, please.
Thank you, Cheryl, Lindsey, and Vanessa, for sharing with the audience the primary ways that you engage in outreach, and also for being very transparent and sharing the information that there are challenges when you are trying to help and reach community members that are facing so many different social determinants of health, finances. So you're touching on every area of concern with consumers, and also building relationship with other organizations to get this work done, to make sure people have the information that they need. And I thank you again for sharing with us that information. So we're just gonna pause here and see if we have any questions in the Q&A right now. Kirk, do you see anything?
Right now, actually, we do have, since Kirk is sharing the PowerPoint, I'm actually going to go ahead and just do the Q&A form really quick. We do have one question at the very top. What type of things do you do while you're tabling at events to attract people to your table? Health insurance can be a dry topic at fun events, quote unquote.
So, okay, Lindsey, why don't you take that question?
I think that one of the things that we have done is to offer some type of an incentive. So whether it is sunscreen or a pair of sunglasses, pens, anything that can get them to your table. The other thing is when we do our outreach events, we typically don't just have a health insurance table. We usually have a health department table. So we could have information on immunizations as well as well water testing. We might have information on safe sleep and the WIC project. So it's not as dry of a table typically, but we like to have incentives to get people to come and talk to us. And if they don't want to talk to us about health insurance at that point in time, we always have business cards available so they can call us when they're ready to talk.
Vanessa, do you have anything to add to that question?
Yes, Cheryl, basically the same. At Family Health Center, we are even planning to have little quizzes or things just to get people engaged at our tables and to give some gifts, you know, when they answer the questions, spin the wheel kind of the thing, and just to make it more fun and approachable to people. That helps a lot.
And how about you, Cheryl? Maybe you have some differences from what Lindsey and Vanessa have just shared to provide to the audience or the person that asked that question.
The biggest difference I could say that we had is with our people, depending on the event, we might be doing something with them or the kids, whether it's jump rope, or we might even have people out there hula hooping. But we try and draw them into us the same way. We do have it, just not our department. A lot of times we have several tables from the health departments because we have so many different programs within our health department to try and draw them in. But definitely, as Vanessa and Lindsey was saying, you always have something there to attract their attention. We use a lot of things with bright colors that have our name on it and make sure that we have flyers there. We have several of us there that we talk to them, and maybe we to ask them before we give them something. Can I ask you a question? A lot of times people are just there to grab items because it's free. But if you start engaging with them, they're very willing to talk.
Wonderful. Thank you for sharing that. And then I just want to add as well that when you're at these outreach events, you know, one thing to think about is the audience that you're targeting. So you want to target your activities to kind of mirror what might draw their attention. You know, if you're at a back to school event, you do want to have table-friendly activities at your station that will draw parents as well as the children and keep them engaged. And while you have them there, you can share the information that they need relative to healthcare, enrollment, and any other resource information that they may need. Thank you so much. Do we have any other questions, Mike?
Yes, actually, we do have 3 currently. One I will go ahead and type the answer to, but for our next one, it actually flows really well. What strategies have you found to be effective in connecting with underserved and underinsured populations?
Vanessa, you want to take that one on?
Absolutely. Thank you, Cheryl. I think we are talking too much about people coming to our tables or, you know, when we do events or participating in events. But what I've seen very useful to do is to go to them. Don't expect them to come to your table. Just grab a couple of flyers, go to them, and reach them where they are at. That has helped me a lot. I have participated in, you know, back to school events, things like that. They don't come to me sometimes because they feel like, okay, what is this person gonna tell me about insurance? It's super boring, right? So I go to them. If they need interpretation, well, I offer interpretation if I can do that. And while I interpret for them to get services at the food pantries or other things, I just share about health, you know, health coverage, you know, Badger Care or healthcare.gov, whatever the case might be. And that has been useful just to start up conversations. I had a boy coming to my table with his mom, and he just, I mean, when I asked, how are you doing? He started sobbing and just crying at my table. And just, you know, talking to him and asking him, how are you doing? What are you crying? Can I help you with something? And he started opening up to a very, very sad story. By the way, he was feeling frustrated, depressed at school. So I could share some information about United Way or the other programs with his mom. So just a simple, how are you doing? Might open up a very meaningful conversation too.
Yes, thank you. Thank you so much for sharing that, Vanessa. We do encounter in outreach activity many stories such as you just mentioned. So thank you. And in essence of time, Mike, why don't we just get that last question in?
Yeah, absolutely. And then we will go ahead and post any questions that are not answered today on the website afterwards, and we will try and get our speakers to assist with those. But for right now, we've had issues with school leadership in our area saying they would like to help get word about insurance, but fear parents see it as too political. How do you break down this thought?
Cheryl, you want to take that one?
I can't really say how to break it down, but I will say this. I did work with a couple of schools, just going to the schools, giving out flyers, letting them know we were here to help. A lot of times parents will feel this way or not really speak on it because they're embarrassed. They're unsure if they can afford it. And some of them are embarrassed about just having state benefits. So what I did was I reached out to a couple of schools, me and the entire team. It was part of our outreach. We would go drop off flyers, just talk to the person in the main office, ask them, can they just sit flyers there to explain to them what our programs entail, so that if a parent is just in the office, they can pick it up, or some added it to their school newsletters. So I think that helps a whole lot.
Thank you so much. And thank you, audience, for those questions. And now we're going to move on, Mike, to that first poll question. So this first poll question in Connecting Communities is, how often does your organization either participate in or host outreach events? And you have three choices there: frequently throughout the year, a few times during the year, never, because you may be experiencing some staff challenges.
And we'll give that another about 15 seconds or so to answer, and then we can close that out and share the results.
Awesome, thank you. Okay, so we have across the board, which is very good to see, that the majority, 42%, frequently throughout the year, with 38% a few times during the year or rarely, and at 20% never, because we have staff challenges, and that does happen. But as long as we're working on getting out there into the community and getting information to our consumers, as long as the effort is being there, then we are doing what we're supposed to be doing. Thank you so much for posting these results. And Kurt, we will move on to the next question that we have for our panelists here. And that is, what are the primary ways you engage in outreach? And we will start with, next slide, we'll start with Vanessa.
Thank you, Cheryl. So I start up by identifying outreach priorities, just immersing myself in the culture of my consumers. I think everybody does that. It's just reviewing what you already do, maybe. But if you try to outreach a specific ethnicity or race, of course, you need to immerse in the culture of your consumers, or even if they are Americans, the same thing, because in different regions we have different cultures too. So just learning where they do work, you know, talking about the Hispanic community, I mean, they work in farms, factories, they have no benefits, is financial assistance their only option, etc. Just getting to know them. And after that, I mean, just educate them, just plan an education outreach, you know, and based on the culture of your consumers, not your preferences. This is very important, because sometimes we try to outreach in the way we would like to be outreach, and we need to sometimes customize written material, adapt our language or vocabulary. Talking about the Hispanic community, I mean, we have people coming from rural communities in South America, Central America, and we have to adapt to what they will understand. Insurance is complicated as it is, and we need to really emphasize what they want to, how they learn things. And again, just learn what places they frequent, their traditions, their family composition, their struggles, their priorities. And something that is being very useful for me, it's just networking with other agencies or programs, because maybe other agencies already canvassed the area that you want to outreach, and they have already results, that you can be part of, or you can be part of the change, just networking with other agencies. Next slide, please. So what I have learned through my research results, talking about the Hispanic community, although I don't only do Spanish applications for Badger Care or healthcare.gov, I would say 70% of my healthcare.gov applications are in English. And there is a reason for that. The facts are that Hispanic patients rely heavily on financial assistance and free clinics. And the cause is immigration status. They don't qualify for healthcare.gov or Badger Care, except for when we have pregnant ladies, of course. And only 20% of Hispanics in my area have a legal status. We have immigrants from Nicaragua coming to our area under the asylum or refugee status, and maybe they might qualify for Medicaid sometimes, but the children are in need of mental health services because of the traumatic journey they had coming to USA, and we try to connect them to resources, and sometimes they are being denied because they cannot get Badger Care right away. So another cause is low health literacy. We have the first generation and second generation of Hispanics. The first generation is the families that just come to the States. The second generation is the children. They are serving as interpreters for the families, and sometimes they are only 6 years old, and it's a challenge. Really, it is a challenge. And the other challenge is the expectation of free healthcare. Back in our countries, we have universal healthcare, and when we have Hispanic families coming to the USA, and well, they expect healthcare to be free. So that's a challenge. We have to educate them and let them know the sad news that here healthcare costs and they need a type of coverage or financial assistance. So another challenge is, of course, the language barrier, the lack of resources, just connected people to, sometimes they have kids with special needs. We connect them to birth to 3 or county programs. I mean, just looking at the person as a whole, we have to do that, because otherwise we just give them a temporal solution to their problems, but we want to do more. And another is health is not a priority. That's what we see, an overuse of ER services and your urgent care, because our Hispanic population are just waiting for things to get really bad to see the doctor. And they are not used to primary care due to the inability to pay and lack of health insurance. And sometimes health insurance premiums payments are seen as a burden instead of a need. Even if they are offered job-sponsored health insurance, they came here to make money and send money back to their countries. So health is not a priority. Just having that paycheck deduction, it's not a good thing for them. So that's another challenge. Please, next slide. And so after you have your research action and research results, you have to come up with a strategy. And for me, has been the holistic approach. So just taking into consideration the social determinants of health. If you struggle to make ends meet, that will lead to financial issues. That in turn will affect your mental and emotional health. That will lead to physical problems. And then that will lead to more financial issues because you're going to the ER instead of primary care services. So it is a cycle that never ends. I think just putting yourself in the shoes of your consumers leads to empathy and better customer service, awareness of the different resources we have in the community, just showing people we care not just about health insurance, but the whole person. We can refer people to organizations or agencies without endorsing any agency, but people want to see we do care, even before talking about insurance. So that's something that we emphasize on our video cast, just letting people, just making them aware of the different resources we have. Sometimes we get referrals that we think are for health insurance coverage, and it ends up being a workers' comp case, you know. So that's why we team up with a workers' comp lawyer in Madison, Legal Action of Wisconsin, because they work at farms, they are being treated unfairly. So that has helped a lot in my navigator outreach. And we will transition over to Lindsey. Thank you.
So identifying outreach priorities. How do we do this in LaCrosse County? We definitely use our CHIP to guide our work. But one of the biggest things is, do we have staff capacity for outreach in the community, and what does that look like? Up until last February, I was the only one in the health department doing the outreach. We were very fortunate to hire another social worker in February who has begun doing some Badger Care food share outreach with me. And that has expanded what we've been able to do. We never like to say no, like we don't have the time to do things, but one person can only do so much. So another thing is to remember to partner not internally only with your sections of the health department, but internally with the county as a whole and with your partners in the community as well. Some of our strategies and things that we have done within the past year are always trying to get to events that are going to be attended by potentially eligible people. Like I said, we do forward health outreach, so primarily Badger Care food share applications when needed. And we always have written information available for people to take with them, not only with our name and ways to contact us, but what we're able to offer them, not only in regards to forward health outreach, like I said before, but that the department as a whole is able to offer them. We have worked very closely with some of our community partners with their newsletters, even having our information, how to contact us on local school web pages, as well as in their handbooks. I have a principal who reaches out usually July, and says, are you still the contact for individual Badger Care help? A local elementary school. So we've had that partnership and relationship for several years, and it has been great for her students and families that she works with. Like I said, partnering not only within our department, but in the county system with our social workers who work with foster care Medicaid, and our staff that work with youth that are transitioning from foster care to independent living. And what does that look like? And giving them somebody at the county level that they can reach back out to for questions and concerns, in addition to the consortia. We have had great partnerships. We have 5 or 6 different school districts within our county alone. And one of the things that we did for our Ren kickoff was a Badger Care 101 presentation. We were able to go ahead and partner with economic support and have them do just a 1-hour overview on Badger Care. And some of the school professionals came back to us and said, we can't attend because it's not during our contracted hours. It was held the last week in July. And economic support said, we are happy to go ahead and do it again for school professionals. So we're hoping to go ahead and have a Badger Care 101 specifically for our school professionals towards the end of October, just giving them time to get their feet on the ground and identify the families and that they're serving right now during the new school year. We have been invited to the social work and care coordinator meetings at the local hospitals to tell about our one-on-one application assistance, but also about how we may have other programming that can help their clientele and their patients. We always try to figure out, like, where can we get our most bang for the buck for outreach? And during the month of August, we partnered with Second Harvest and we did their mobile food pantries that were located within the Western region. And they ended up being in Monroe County. So in Sparta, Norwalk, and Toma. And we went, Carlene, the other social worker, and I, for Toma, went vehicle to vehicle and just asked, do you know anybody who's on Badger Care or Food Share? And we didn't want to say, are you on Badger Care or Food Share? We wanted just to say, do you know anybody? And a lot of the times they would say, yes, I'm on it, or my child is on it, or my neighbor or my coworker. And what we were able to do was to give them just some basic information about making sure their address was updated. Basic information about how the PHE, when it ends, we want to be able to make sure that they're getting information that could affect their benefits. And so by doing this, partnering with the Second Harvest mobile food pantry, we were able to go ahead and reach roughly 140 households per outreach event. We also looked to see like what's time sensitive. Last year, LaCrosse, the city of LaCrosse had rented out a hotel, and they put our unsheltered, our homeless in it for the winter. And when that was going to close in March, April this year, Carlene and I were able to go and just to talk to the people that had been staying there to make sure that their address was accurate, that they weren't using that hotel address, and that when the PHE ends, that their information would be sent to the hotel that they weren't at anymore. So we worked with them to get addresses updated. And then we always work with the one-time events that come around, usually annual events. So back to school, immigration wellness fairs, family fun fest. We weren't able to go ahead as an individual and attend Juneteenth or the dairy breakfast, but the county as a whole had a table, and we were able to go ahead and provide information that people could take from that. Next slide. And then this is just some things that we've done probably within the past 4 to 6 months to show that we are out in the community a lot. Carlene was on vacation 1 week, and so I asked economic support, by chance, do you have any economic support staff that would like to or be able to attend one of the Second Harvest mobile food pantries? And they said, absolutely. So at the bottom middle picture is Maria. She's one of our economic support specialists. She was able to come and spend about an hour and a half as we went car to car and gave information to the people waiting for the food packages. And then in the top right corner of the screen, Carlene and I with Maria and another economic support worker. The community that we were doing that food distribution in has a high Hispanic population, and we didn't know if there would be a lot of Hispanic people that were coming to access food. And Carlene and I did not want to have a language barrier, and economic support said, yes, we have 2 bilingual staff that would be happy to join you that day. So it was phenomenal that we were able to go ahead and again, partner with our economic support office to get their economic support specialists in the community to meet the people that they are serving through their call centers. Another thing that I like to talk about is that even if it's not a big giveaway or a wellness fair or anything like that, we try to entwine our Badger Care information in everything that we do. So whether it be a clothing giveaway, we go ahead and we put a sheet of paper in there about making sure your address is updated. And also that if they call and they need help with over-the-counter medications, we check to make sure that their address and information is updated and forward help for them as well, and help report changes. I think there's a lot of opportunities to go ahead and help people apply for benefits and make sure that they have the education and information that they need to maintain those benefits throughout the years if they're eligible as well. Cheryl has the next slide.
Okay, sorry about that. just make sure you know your local landscape. Know exactly where the food deserts are as far as the food share, things of healthcare. We focus a lot on the 53206 area code here due to the fact that we know that there is a food desert in that area. And usually where there's food deserts, people are not taking care of their health. So therefore, we try to make sure that we look at all that. One of the food pantries we hit is in that area. And with doing so, we are able to hit them not only on the food share aspect, but we also ask them, what about their health care? Some people come and think they don't have health care, or unsure what kind of health care they got. Know your consumers and their challenges. When you know this, you encounter people, like I say, who believe that they're uninsured or what kind of insurance they have. A lot of times if you sit and you talk to them, they'll be like, I don't have any health care coverage, or they're unsure. We meet a lot of people here who have health care, but is unsure if they have any at all, or don't know that they have it. Make sure you focus on building relationships. We are learning to build relationships with a lot of different people. And what I mean by that is working with MCAM, covering Wisconsin, things like that. We constantly are getting more outreach. Our outreach focus have been on our own personal. The health department every year does, well, this year is down to 1 back to school fair. Last year when I first came in, we did 2. We also work with other departments within our agency, such as WIC. WIC does a big community resource fair, I'll say. We're all out there, we're participating, and we're getting to know our community and who needs what. So what I mean by that is we as well have 2 Hispanic speaking bilingual workers here who are very good with connecting. They make their own connections as far as different things in the community. They might work with a church or a different group of people. And luckily our whole team is willing to jump in and help. So we are very small in our department, but we do a lot of outreach. What I mean by that is we can go to several different places to the point where we might have 1 staff member at 1 location, 2 more at another, and 1 person working offices. So we do really use our resources to the best of our ability, and we try to use our connections. If we're short on staff and we might have a partnership with another agency, we might ask them, can they hand out flyers for us? And we'll hand out some for them as well, just to make sure that people know that the resources are available. And consumers are more likely to discuss their benefits with you if you are asking them questions such as Vanessa stated, do you know anybody who needs assistance with healthcare or food share? They might say to themselves are interested in it, or they do have it, but they need help with explaining how their benefits are working or problems that they're having or encountering. Next slide.
Thank you. Thank you, each of you, for sharing those identifying, prioritizing that you do with engaging communities, using your resources, using partnerships, building those relationships. All of those things are key to getting that great outreach out there in the community for people to receive the information that they need. In the essence of time, Kirk, I think we're going to bypass the questions at this point and bring it to the end and just go straight, Mike, to our poll question number 2. What social media platforms does your organization use to reach consumers? And those choices are Facebook, Instagram, Snapchat, Twitter, YouTube video, e-news, LinkedIn, WhatsApp, or none of the above. So if you could just go ahead and take that survey, and Mike will let us know what the results are.
All right, we'll give that just another about 15 seconds, and then we'll close that out and show the results.
Wow, okay. So it looks like the majority of our audience are utilizing Facebook. So Facebook is at 65%, while a few of the others are with Instagram, Twitter, and YouTube are kind of equal across the board, while Snapchat and WhatsApp are very rarely used. But we do have all of these social media platforms that are available with creative from our different sources that we talked about earlier, that should you want to begin using some of those social media types, there is the creative there available for you to use to reach consumers. Thank you so much, Mike, for handling that poll for us. So I guess we do have a little bit of time. So Kurt, do you see any questions in the Q&A for our panelists to answer when it comes to identifying those outreach priorities?
And actually, since Kirk is still sharing the PowerPoint, I will go ahead and answer that for him.
Okay.
And then let me see, it looks like we have 2 questions here. All right, it looks like people without social securities is a challenge in my area. Are there any insurance companies that will take these people?
So Lindsey, do you want to answer that question?
So the question is people without social security numbers, is that the question? I am not I guess I work with Forward Health, and so the only people that we would be working with potentially are going to be the for Forward Health, pregnant women, and then the emergency Medicaid. But I don't know if there are other health insurance plans that would be an option for. We would also refer them to our local FQHC and our free clinics in the area.
Okay, great. Mike, maybe that's a question that we can come back to that that person with at a later time and put that question on the website for them. That answer,
Yeah.
I'm sorry.
Absolutely. And then our next question is, my free clinic would like to do more outreach, but we are maxed out on capacity, and so it feels dishonest to say that we have available services. Do you have any advice on strategies to recruit committed volunteers to your organization?
Cheryl, would you like to, since you did speak a little bit about those staffing issues, address that answer for this person's question?
Luckily for us, our staff is more dedicated than you know. So they spend a lot of time doing outreach. A lot of times our outreach is done on weekends. So as for me, I could do a lot of outreach on weekends, going to different places. I might hit more than one location. Also, I do what I call walk with chat. I might walk through an event with nothing but flyers and just walk up to them, approach them, ask them questions. Hey, are you enrolled in Badger Care? Do you know anyone who needs any assistance with healthcare or food share? Staffing and trying to table at an event sometimes can be very challenging, especially if your staffing is low. Maybe give them an incentive as far as, how about let's flex some of your time? If you can go and do this event for me, maybe we can give you 4 hours off here, or maybe we can let you come in a little late there. I think that challenge of being short on staff is a hard thing, but definitely try to give your staff some kind of incentive to show them how much you appreciate them. Or like I say, do something as simple as walk through an event, maybe take an hour time and walk through an event and just try to talk to people. You'll be shocked how much response you'll get back by just walking through and trying to talk to people, depending on how big the event is or what time of the day the event is. That's my best suggestion.
Awesome. Thank you, Cheryl. And that's a perfect segue into our next question. How do you engage partners in your outreach work? Next slide, Kirk. And so, Vanessa, if you could take us into that questionnaire.
Thank you, Cheryl. Yes, so for me, it started just by mapping and organizing my ideas. What were the organizations I wanted to reach out to, and just being very thorough and tracking my every single call, every email that I sent to these organizations. And it all started with H2N, the Hmong and Hispanic Communication Network, as I said before, and just reaching out to Mariana Sabela, fellow navigator, and just brainstorming ideas. So I cannot emphasize enough that your first outreach has to be with your fellow navigators, because you can outreach out to more people that way, and you can even make very good friends. So next slide, please. So I use a holistic approach that I use with my consumers to engage partners on my outreach. I tell them, to the organization I'm planning to outreach to, social and financial struggles lead to health issues, mental and emotional distress. And I tell them I offer and connect people with resources. I connect on a cultural level, like my life experience, because I've been there. I know what my consumers are going through because I was born and raised in Mexico. I know the struggles, and I offer health coverage options and resources outside insurance. That is what I share with the organizations I plan to partner with, just making them aware that I see my consumers as a whole, and that's why I come to them. Whereas it's the United Way, the ADRC, or a family resource center, because we have the same goal and we want to be part of the solution. If they have referrals for healthcare, they will refer those to me. If I have referrals for other needs, I will refer them to their organizations without endorsing, of course. But that's how we work. Next slide, please. So after that, I have found that something really useful when you're planning to outreach community partners, to engage community partners in your navigator work. It all starts by looking at their webpage, learning the names of the people in charge, customizing your PowerPoint presentations if you have meetings with them. Just let them know you're prepared, you know what you're talking about, you're a navigator, you're a CAC. Well, navigators are the ones doing outreach anyway, but just let them know that you are prepared, and just talk their language, learn their work style. And sometimes, it all starts with an email or a phone call with a target organization, and then that leads to a meeting by using Microsoft Teams or Zoom meetings, just to let them know what you do as a navigator, and listen to what they are doing. Get them excited about a partnership. Sometimes, as I said before, you have to customize a presentation, a PowerPoint presentation. I have tons of them. I'm always prepared, because you never know which one you might use in a Microsoft Team meeting, just to get them excited about partnering with you in your efforts as a navigator. And after the meeting, I offer, I send them digital flyers and outreach cards, just to ask them how many they would like to have, to share with their consumers and clients, just to spread the word about Badger Care or healthcare.gov. And appear professional and prepared. This is important. I mean, I know insurance is a heavy topic, but if you appear yourself like a professional person and well prepared, they get excited. If you, even your tone of voice, plays a very essential key on this. So clarify your services. Sometimes when other organizations sends referrals to us, they see us like miracle workers. And sometimes some referrals are very hard. As I said before, our Hispanic community, sometimes the only option for them is financial assistance. And they have to be placed on waiting lists and comply with some requirements for different programs. So I share with the organization that is sending me referrals, I'm going to do the best I can, but I cannot promise sometimes the outcome. I'm going to do my best. So clarify your services and outline your services. That is very important. I just wanted to share what happened with the school district of Marshfield. I started just, calling them, sending them emails. I was very insistent, and they said no several times. So I offered COVID tests and masks. And when I was about to give up, I just placed my last call, and I reached out to the nurse to the mental health navigator and one of the social workers in my calls, and they said, we were just talking about you because we've seen that you have sent several emails and voicemails, and we would like to invite you to one of our meetings to help our Hispanic students and their families. So we need Hispanic leaders. So are you willing to be part of that? And I said, of course, yes. So if you want to know about healthcare, I'm here for that. So you never know what these outreach calls and emails might lead to, because one organization might connect you to 3 more. So it's been exciting, and I cannot emphasize enough, just connect to fellow navigators to reach out more people. If you know about an event, just invite them to be part of that event if they are close to you, and join efforts, right? And we share the same goals. We're not competing, mentor each other, and just participate with each other. And my next slide, actually, I'm going to talk about doing an outreach within your own organization. It is important because if you work in a big organization, they might not know what you do. So just invite people to your events, participate with diversity, equity, and inclusion groups within your organization, work with your community engagement department because they might have great ideas, and accept invitations to present. Always be prepared. I think my outreach has been more digital, talking about partnering with other organizations because they love Microsoft Teams and Zoom meetings. So if you're prepared to do a very good presentation, they get excited, even within your own organization. And together, remember, together we can help to fill in a different part of the puzzle to reach out to a community, even doing an outreach within your own organization. So we are gonna transition over to Lindsey.
Thanks, Vanessa. So how do we partner with our community organizations, and what benefit does our relationship have with them for them and their clients? So we partner with our local nonprofits, our food networks, the school districts, our healthcare providers, our local navigators, CAC agents and brokers, and really it's all about relationships. If we have one person in common that has a trusted relationship, and maybe somebody has been struggling with getting through to the economic support office, through to the consortia, through the call center, and they have at the local shelter has a way to contact me, and we can go ahead and take care of something in 2 minutes versus a 15-minute wait on hold. That not only builds the relationship with the consumer, but also with me as another person that can help people. That's one of our biggest things. Like, we are here to help people, to make sure that they get connected to community resources and services, that they're eligible. And once they're connected, to keep them connected, to make sure that they know what benefits come with the package that they're offered, and what their rights and responsibilities are when they are receiving a service. We've helped clients make sure that they get into the right HMO for the services that they want and the services that they're going to need. We want to make sure people keep their coverage so they can get their medications filled, that they can attend treatment or their therapy appointments. But one of the biggest things is, what do your partners want from you? Like how somebody said before, like, it's a two-way street. We can go ahead and send people one way, they're going to send them back to us. How can we continue to partner for the best to serve our consumers and our community members? And that was one of the questions that we asked at our first REN meeting back at the end of August, is what do you want out of this group? How do you want to benefit from this? What do your clients need? And then trying to figure out where we go from here. And so we have our next upcoming REN meeting at the end of the month. And everything that's on our agenda is stuff that the organizations said that they want. So just being very aware of, it's not all about what we do, but how can we partner and work together, because our end goal is the same, to serve the community in the best way that we can. The other thing I wanted to say is to go ahead and don't reinvent the wheel. If you are looking for resources, I know that they were shared earlier in the presentation, but the DHS Unwinding Partners Toolkit and Covering Wisconsin's how-to sheets have been a great help for us. And we've been able to go ahead and distribute them not only to individuals directly, but to our community partners to go ahead and make sure that they have accurate information. The information that they put out is vetted. It's the best that we can go ahead and get. There's no reason for us to redo it. So we really try to use that information at every opportunity that it is appropriate for. Next slide is for Cheryl.
Thank you. I just want to say this because I know we are running out of time, but just know every encounter you have is an opportunity to engage with somebody or to get a new partnership, whether it's with, whether you're working with whoever you're working with. So a lot of times my partnerships come from working with my nonprofit. What I mean by that is I could be at a nonprofit event, somebody might invite me to something else and they're talking about other things they need. They might tell me they're looking for people to help them figure out healthcare, food share, whatever. That's something I take back. I bring it back to the department and give it to my supervisor who connects us with a different organization. Also, just know, as I said, walk around, find out what these other organizations are offering. Be sure to get their contact information. I don't care if it's as simple as stopping by their table, talking to them, finding out what they have to offer, if they're offering the same things, and make sure that you learn what they're doing. And attend events, even if you're not invited to it, as far as to be a presenter or to table at that event or to give something out. And make sure that you look for every opportunity that you come about, because when you walk around and you talk to them, you find out a lot more than you know. So just make sure that, like I say, you engage with whoever you can. Every encounter is an opportunity, whether you know it or not. You might be talking to somebody and they might be looking for something and you never know what they were looking for because you could be having a whole different conversation. Thank you again.
Yes, and I just want to thank all of my panelists. You guys have just done an amazing job in sharing information on outreach best practices. I really appreciate the time that you have put into making sure that all of your colleagues and the audience does have the information they need to get out there and outreach and do this work. Each one of our panelists can be located here, Cheryl McCarter, Lindsey Schwarz-Nichols, and Vanessa Silva at their email addresses here, and we'll get those in the chat for you. And I did want to give Vanessa an opportunity to address one question that came from an audience member. If you would be so kind, Vanessa, the question was about undocumented applying for Badger Care that would like to, they would like for you to address, and outreach to schools. Can you please take that message, that question, please, and answer very quickly?
Thank you, Cheryl. Yes, about undocumented consumers applying to Badger Care. Sadly, the only ones that could benefit from applying and even qualifying are children who are born here, children of Hispanic, families born here, or pregnant ladies. What I advise to pregnant ladies is to avoid elaborating when they are answering the application over the phone. For example, if the question is, are you a U.S. citizen or a permanent resident? Just answer no, no, no. Not going into details, because that doesn't work. So, and yeah, we don't report to the federal government any of the status of the consumers. That's confidential. So they can apply whether they qualify is up to the consortium. And talking about it, schools, it's just in my outreach to schools, I have shared that, for example, some students have special needs and their outpatient service, for example, therapies, speech, physical, occupational therapy, they are covered under Badger Care, even at school. So I share that with the school district. If you want your students continue with their services at school and it's being paid by Badger Care, it's in your benefit just letting them know about the Medicaid unwinding so they can renew their benefits, even for mental health services if they are receiving counseling that is covered by Badger Care at school. That's what I wanted to share, Cheryl. Thank you.
Thank you so very much for answering that question. I just want to, before we wrap up here, again, thank you everybody for joining with us for, I know we're going over just a little bit, but for sharing this time with us. Hopefully we've been able to cover all of your questions and answers on outreach best practices. And I just wanted to leave everyone with one little nugget before I hand it over to Allison to close us out. Just to remember that targeted outreach for open enrollment, as well as the end of the public health emergency as it looms, is needed. The targeted outreach and enrollment efforts could help more people sign up for health coverage. And that includes the COVID-19 public health emergency when it expires. It will trigger the end of Medicaid's continuous enrollment policy. So it's important to outreach and get that information out there. Well-targeted outreach and enrollment efforts could produce a positive trend line for enrollment moving forward in years to come. We've got to remember that nearly half of uninsured Wisconsinites are eligible for ACA tax credits, and we need to let them know that. And while more than a quarter can be covered by Badger Care, we need to make sure that those folks are getting covered as well. So again, I just want to thank you for your time, and thank you, panelists. I appreciate you so much for sharing your knowledge. And with that, we'll turn it over to Allison.
Awesome. And look at all those love emojis. I love it. Thank you so much. Wonderful session. And so we're going to close it out. This is our last session. You did it, everybody. You made it through. But I think I'm hoping you got a lot out of this. I know I definitely did. Our final gift card winner was Shanice Whitlow. So congratulations to you, Shanice. And everybody else, please, you will be getting an email, a final email from this conference with, of course, our evaluation. It's only going to take you 5 minutes. Please take the time to do that, as well as just a reminder about if you're looking for the credits for licensing in the state, just what you need to be doing and what you need to be looking out for, including certificates that will be sent from us. All right. Well, thank you, everybody. And we are looking forward to seeing you at our next event in the future.